And the next debate is a topic of great interest, and it relates to genetic testing. The question is, has genetic testing improved care for people with epilepsy? We now have sophisticated genetic testing available at reasonably affordable prices in recent years. It's often covered by insurance. The prices have fallen considerably. And these can provide specific information about the underlying genetic abnormality, give us a more precise diagnosis, and in theory, in certain people, may lead to precision in therapy. The question, however, has genetic testing lived up to its promise, and does it provide clinically useful and meaningful information? So we have two speakers today, both experts in this area. The first is Alicia Goldman, who is an epileptologist, associate professor of neurology at Baylor University in Houston, Texas. Her practice and research is focused on translational genetic investigations of human epilepsy and sudden unexpected death in epilepsy. She established and directs the Adult Epilepsy Genetics Clinic at Baylor College of Medicine. And the clinic's focus is on uncovering genetic causes of epilepsy in patients with epilepsy of unknown or presumed genetic causes. And she has a laboratory for translational epilepsy neurogenetics, which focuses on the analysis of human sequence data and actively explores genomic structural variation in the candidate epilepsy network. Her opponent, who will take the position no, so Dr. Goldman is saying yes, is Dr. Nicola Specchio, who is a member of the Department of Neuroscience at Bambino Gesù Children's Hospital and the Institute for Research in Healthcare in Rome, Italy. He's head of the epilepsy unit in the Department of Neuroscience. And within his role, he's responsible for the diagnosis of and treatment of patients with pediatric epilepsy. His main interest lies within seizure semiology and the classification of seizures and syndromes, drug-resistant epilepsies, and these developmental and epileptic encephalopathies. He's received numerous awards, and he's the current chair of the ILE Task Force on Nosology and Classification, which has 4 papers coming out in epilepsia very soon, and they're all either online today or tomorrow or the next day, or certainly within a few days. So with that, we will now move to an initial vote for everyone. I'd like people to vote. Has genetic testing improved care for people with epilepsy? Do you think that the case is yes or no? And please cast your vote. After the vote, we will then have the two speakers provide their arguments on either side, and then we'll have rebuttals.
Hello. Thank you very much for the kind invitation to participate in this very interesting and important debate. So I am tasked to convince you that genetic testing is important and clinically relevant for patients with epilepsy. I don't have any relevant disclosures. So when we look at the trajectory of articles that were focused on genetic testing in epilepsy, it is evident that the discovery of the first human gene for epilepsy in 1995 spurred a lot of interest in exploration of molecular diagnosis for human epilepsies. And the application of next generation sequencing in 2005, their introduction into the genetic testing paradigm has been extremely important in facilitating exome and whole genome analysis of genetic underpinnings of human epilepsies. However, when we think about genetic testing in epilepsy, it is important to consider whether we are using it to look at very rare or relatively common entity. And I'd like to convince you that in epilepsy, the genetic underpinnings are common. We know that the lifetime risk of epilepsy in the United States is estimated at 1 in 26 persons. Now, what proportion is genetic? And I'd like to argue that it's most of it. Genetic underpinnings, whether it is causation or predisposition, is linked to generalized as well as focal epilepsies, and it operates along the continuum. And there is now growing evidence that even epilepsies that were considered acquired, there is a genetic vulnerability towards their expression. And it is not surprising that genetic epilepsy is common, given the extreme complexity of neural network in humans, the fast rate of cell divisions during the brain development, the high burden, the high estimated burden of variation that occurs during brain development, and also the many pathways that can potentially be affected, and therefore many ways to create epilepsy. But when we are talking about genetic testing in epilepsy, it is also important to consider what we are testing, especially when we are trying to understand the yield of genetic testing. While we are looking at a very important component of genomic information, it is still just a part of genomic information when we are analyzing DNA. And typically, we are analyzing venous blood DNA in patients with epilepsy. And we are looking on the DNA level at the scale of variation, from chromosomal rearrangements to a smaller type of large structural variants, so-called copy number variants. And then we have our small type of structural variants, either single nucleotide variants or small insertions and deletions. And these are being analyzed on two main platforms. So the small type of structural variation is being detected typically through next generation sequencing, whether it is applied through multi-gene panels, exome sequencing, or whole genome sequencing. And then we have chromosomal microarrays that are being used in clinical diagnostic laboratories for detection of copy number variants or for their validation, since there are now tools to infer copy number variants from exome or genome sequencing. Now, if we go through the expense and the effort of doing genetic testing in patients with epilepsy, even though the epilepsies or genetic epilepsies may be common? How frequently are we going to meet the expectations of the clinicians and the patients? So there were many studies that have been looking at the question of diagnostic yield in genetic epilepsies over the several years. However, because in the interest of time, I'd like to focus on meta-analysis that was done by Beth Scheidley and her collaborators and published this year in Epilepsy. The authors looked at all the studies that dealt with yield in genetic testing in epilepsy published in English, and 154 articles met their inclusion criteria. Now, first they looked at diagnostic yield across testing platforms, and they show that chromosomal microarray yields causal copy number variants in about 9% of patients. When we look at smaller type of variation, and we are using next generation sequencing, multi-gene panels tend to detect causal variation in about 19% of patients. Whole exome sequencing tends to be diagnostically positive in 24% of patients, and whole genome sequencing twice that rate. But now, which patient population is most likely to have diagnostic genetic testing? So when the authors looked at patient categories, they noted that across the board, patients with developmental epileptic encephalopathies tended to have the high yield of diagnostic results. Whether it was done, whether they looked across all modalities, or whether they looked through multi-gene panel or exome sequencing. And of note, the yield of multi-gene panel tends to be, as expected, tends to increase as expected based on the number of genes we have on the panel. Next group behind patients with developmental epileptic encephalopathies are patients with epilepsy and comorbid neurodevelopmental disability. And in this situation, chromosomal microarrays will yield pathogenic causally linked variants in 9% of patients. And please note that in patients who are negative for who don't have coexisting neurodevelopmental disorder, the yield is 1/3 of that. Similarly, if we are looking at gene-based structural variants detected by next generation platforms, patients with epilepsy and neurodevelopmental disorders will have diagnostic result in 27% of them. Now, the patients that tend to be difficult to diagnose genetically are patients with focal epilepsy, typically focal non-lesional epilepsy, where the yield hovers around 7%. It's not the case in patients with structural brain malformations, where studies that looked at that typically used multi-gene panels and were able to resolve about 54% of these patients. And when we get results from diagnostic testing, from genetic testing, it is important to consider that it not only has and carries clinical utility, but also personal utility for the parents or the patient. Not only it can help us to confirm clinical diagnosis, many times it can help us to prognosticate. It may lead to early detection of symptoms. aid in diagnosing comorbidities or high-risk outcomes, help us to screen for adverse reactions, may have therapeutic implications, and it can inform family planning and genetic counseling. And last but not least, it may facilitate enrollment of patients into clinical trials. Now, when we do genetic testing, the number one hope and expectation of patients and parents frequently is not only to understand the cause, but then how do we use this information to improve treatment. And there is a small group of patients, typically patients with monogenic epilepsies, where genetic testing and understanding functional impact of the pathogenic variant can inform therapeutic decisions, whether it is choosing from the array of existing drug that may be most likely to be effective in treating these patients, or whether we then look to alternative treatment approaches outside of standard anti-seizure medications. And the last thing is that there are now efforts to try to detect, to try to understand the molecular defect early, so that in devastating forms of epilepsy, we can institute the medications essentially preventively, as is the case in tuberous sclerosis or pyridoxine-dependent epilepsy. And as I mentioned earlier, understanding and having the molecular diagnosis can also help us to refer patients to clinical trials and also makes specific patient group eligible to novel or established therapies restricted to these patient groups. So I would like to end with an excerpt from ILAE position paper on classification of epilepsies. And the reason why is because it stresses the importance of precise clinical diagnosis of epilepsy and thus classification. And I would argue that precision diagnostic of epilepsy, that in the precision diagnostic of epilepsy, we ought to consider including genetic testing into the diagnostic paradigm that presently includes your careful clinical phenotyping, EEG, and imaging. Thank you.
Good day, everyone. It's a great pleasure to be here today. Many thanks to Mike for your kind introduction, and many thanks for the organizers of the 16th World Congress on Controversies in Neurology. So my duty today is talking about genetic testing, if genetic testing improve care of people with epilepsy, and I would try to convince you that the correct answer is no. So let's move, this is my disclosure. And let's move to the outline. I'll start with discussing briefly about the approach of genetics, and then the meaning of genetic diagnosis, and then moving to the limitation of the NGS panels, genes and syndromes, so how to apply for a single gene to a single syndrome, and then moving to some other limitations and conclusions. So let me start briefly here saying that this is something that really was very nicely pointed out by Alicia, that a number of genes are responsible for the epilepsies and developmental and epileptic encephalopathies, and we have more and more genes, which is a good thing for us in order to get the patient's diagnosis. And why we need genes? Because we need to complete the genetics research cycle, moving from the phenotype to the identification of the cause, and then all the others, the characterization of the phenotype in terms of mechanisms and the diagnostic. However, let me say that despite we have a number of genes, we are not moving from phenotype to genotype, but what we're doing right now is moving on the way back from genotype to phenotype. And why we need genetic testing? Essentially because of prognosis, because of therapy management, because of understanding comorbidities. And why we need an early genetic testing? Because it is affecting the therapeutic choice. That's true, but we will see the results of the genetic testing. And let me say really briefly two cases. The first one was diagnosed in 7 years. The second one was diagnosed in 2 months. The first one was a patient having KCNQ2 developmental and epileptic encephalopathy, similarly to the first one, with clinical findings very similar, but with a huge differences in time of diagnosis. And despite this, what is changing for those patients? So there are some limitations of NGS panels. So in terms of genetics, the detection of a low mosaicism, there are the timing of analysis may be not so quick. And there is the problem with variance of uncertain significance with NGS. And variance of uncertain significance, when we have a patient and we don't have clear in mind the phenotype. So it's a patient with a complex epilepsy, with complex type of seizures, multiple type of seizures, EEG not reporting to a specific syndrome. And we found a variance of unknown significance. This is really tricky. So there are some limitations in databases, limitation in the literature, and therefore the clinical interpretation may be limited. So we have results of genetic, but we don't know how and what to do with that results. Time to time it happens. Fortunately, in some situations, we know that there is a genotype and a phenotype, and we know that it is very useful because we have a treatment that may be more appropriate rather than other treatments. And you have here a list, I'm not going through that one. However, even in this situation, there are some limitations for targeted therapies. So if you have a patient with a gain of function variance in SCN2A gene, it is suggested to use sodium channel blockers, but not in patients with loss of function variants. So this is another step, another difficulty that we as a clinician are in front of when we have received a report from the geneticist. And the genetic research strategy is quite complicated. So the idea that one syndrome may one gene may correspond to one syndrome is not that the case anymore. So we may have one syndrome with many genes behind that one, or on the other side, we may have one gene with many syndromes. So that's something that complicates the clinical picture and that complicates the interpretation of results. And you see here, for example, this is the SCN1A phenotypic spectrum, starting from the DEE, Dravet syndrome, but also other conditions, and going toward the self-limited conditions like genetic epilepsy with febrile seizure plus. The same may happen to the SCN2A phenotypic spectrum. So moving from DEE to self-limited or self-limited epilepsies. So that is another complication. So are we sure that having new genes, having the possibility of diagnosing patients with a genetic basis is really implementing the care of our patients? This is to be discussed. And if you look at the current approach. So we had, as in the past, the electroclinical classification. Now we have the etiology classification of syndromes. We have the KCNQ2, SCN8A, or whatever it is, gene name, encephalopathy. And the etiology is recognized much before the electroclinical picture, which is good, but not always helps patients. And here is another example on the KCNQ2 self-limited epilepsy, together with KCNQ2 developmental and epileptic encephalopathy. So here are the clinical criteria. And if you look at the differences, what is really making the difference here at the beginning, at the very beginning, is that in some patients with KCNQ2 mutation, the EEG pattern correlates better with prognosis rather than molecular genetic findings. So that's something that we need to keep in mind. The EEG and the phenotype and the clinical finding should not be forgotten. So another problem with targeted therapies, which is one of the aim of the early genetic testing. So efficacy currently is not in 100% in seizure control, and treatment is a treatment that is done looking at seizures, but not on cognitive functions, not on behavioral disorders. And we are still missing the treatment of multi-system features in some syndromic patients. And also, when we have new gene variants, unknown gene variants, I mean, new genes, and if we don't have functional testing, it's really difficult to move forward to a targeted therapy. So that should be considered very carefully. And if you look at, for example, the comorbidities for some patients, you see here that, for example, in some developmental and epileptic encephalopathies, here you have in the blue bar, it represents the epilepsy onset, and the red bar represents development of the onset of developmental delay. So even if you're able to interfere in some way with seizures, you are not able to interfere with developmental delay. And also, in some patients, developmental delay starts a bit later, or in some other patients has CDKL5, CDDs, deficiency disorder. It is almost overlapping. So interfere with the process is challenging. Another example is SCN2A related epilepsy, a response to anti-seizure medications. It depends upon the phenotype. So the early infantile epilepsy, so the DEE, and also the late infantile responding to standard anti-seizure medications. And then you have the phenotype characterized by autistic spectrum disorder and intellectual disability. So looking at the phenotype and putting together genetic data with the phenotype, we may act in some way, but not always we can resolve problems. And you see here, despite we are now very nicely, we learned it very nicely that we need to use sodium channel blockers in SCN2A DEE, the presence of comorbidities is really wide, and this is the same for SCN8A developmental and epileptic encephalopathy. Here I'm just showing you 3 epileptic seizures recorded with video EEG of SCN8A patients, just saying that this is this may reflect a specific phenotype for those patients. And you see here on the polygraphic channel, you have a significant bradycardia here, and you have a tonic seizures with prolonged diffuse contraction. And this is seizure number 1 in a patient. And if you look at the, okay, this is a enlargement of the same figure, and you see the bradycardia on the ECG. And this is another patient, and presenting the same bradycardia, the same tonic seizure, the same EEG activity. So, and this is a number 2. And again, this is number 3, so presenting once again the same symptoms. What I would like to tell you guys is that with SCN8A, we have some kind of seizures that may reflect the genetic counterpart. I mean, several patients with this genetic mutation, they present with similar seizures. So that's useful. But if we start with looking at the patient, we may better understand the genetic results. And again, SCN8A is not only seizures. You see a number of comorbidities from low muscle tone, physical weakness. So even if we know that we are using sodium channel blockers in those patients, but there are still a number of things that we don't know. Another example is tuberous sclerosis complex and targeted treatment. Vigabatrin and everolimus, they are not definitely changing the natural history of the disease, despite we aim for such kind of findings. And you see here, despite we're using those medications very early during the disease, despite a number of papers, including the EPISTOP trial, said that we need to use that one, vigabatrin, very early, it's turned to be difficult to have then long-term effects in terms of outcome, both of seizures and cognition. And here you have another example of the KCNT1 related epilepsies. And if you look at here, the outcome of kinidine treatment is, in the majority of patients, is not so exciting, even if you may have some anecdotal cases with a much better improvement of findings. So let me go to the last couple of slides. And the last topic that I would like to share with you in the last minutes and a half I have is the ultra-rare genetic epilepsies. So the advances in NGS, we have more diagnosis, but we may detect rare variants in ultra-rare diseases. And we really may have difficulties in the assessment of prognosis, and specific treatment may not be available. So that's another story. That's another issue that we need to keep really in mind. And if you look at this data, only half of patients, not only half of patients are undiagnosed, and some of them are unresolved, they're negative, and there are no access to any targeted therapies. So, conclusion. There is a limitation of genetic testing since now they're available in clinical practice. Of course, I love genetic testing, but if the question is, as genetic testing improved care for people with epilepsy, we may argue that, of course, it's not full yes, but it's not full no. We should discuss about this. And the interpretation of genetic testing. So despite advanced tests, we have to insist on the importance of the phenotype description to be sure that we're selecting cases with same disease and reevaluating the role of pediatric neurologists. There are undiagnosed and ultra-rare patients. There is a limited access to functional studies. So if we have a genetic report, we still not always know what does it means. And always keep in mind that one gene, one disease does not exist. And so there is one syndrome, many genes, or one gene, many syndromes. And finally, targeted therapy, unfortunately, are not working in all cases. And we're still far, let me say, with a real precision medicine. And I thank you. I thank you very much for your kind attention, and I hope we will have a nice discussion. Thank you indeed.
Okay, can you hear me now?
Yeah.
So thank you very much, Alicia and Nicola, for very interesting talks. We will next proceed with rebuttal first. If each of you can take a few minutes to make a few comments, rebutting what your opponent in the debate has said, and then we will open it for general questions, and then finally a repeat vote. So Alicia, you have first shout at rebuttal. You need to unmute, of course.
Thank you, Mike. I appreciate being part of this discussion. This is really exciting. Now, I really enjoyed the presentation of Dr. Specchio because he really brought to the fore the complexities that we are facing. And yet, I would argue that genetic testing has changed the way we practice medicine, practice neurology. Because just looking at my patients, and I am on the adult side, I look at the adult patients and they, when I look at those, the small fraction that ever had any genetic testing done, if you would have asked those patients, asked the physician 10 years ago, they would say, well, the genetic testing really is not affecting the practice. And yet we are able to resolve them now in their adulthood. And that changes the way we look at their disease, what we can do. Just one example is a patient who presented with several different seizure types, and he was geared for surgery. And when we did an evaluation on the genetic testing, and he found pathogenic variant in NPRL2 gene, suddenly it became clear that this is not a focal form of epilepsy that is going to be remediable by surgery, but it is a multifocal epilepsy of genetic cause, and we really need to be looking at different modalities, how we influence this. So it does change that. I still would, I would agree on one point, that is that we are not, we cannot simplify the paradigm of genetic testing and the interventions from genotype to phenotype, but I am actually in the camp of Dr. Cilio and Dr. Specchio that we really, this even more stresses the importance of careful phenotyping and identifying endophenotypes and paying attention to the comorbidities. And then the genetic testing can be very helpful because as a paper that was in New England Journal of Medicine published in about 2019 or 2020 showed, there is definitely also a polygenic influences that we are looking when we are looking at epilepsy. So essentially we are looking at epilepsy plus single gene plus. I mean, this is going to be more polygenic, in many situations, polygenic influences. And the other point that I would like to say is that the targeted therapy, yeah, we are at the very beginning of the targeted therapies, and there are many questions in terms of the when and how and what we use. And in many situations, we will be looking at allele-specific therapy, and we need to understand, and we have a bottleneck of variants that we don't understand how they act. But there are some new exciting bioinformatics developments, such as the work that has been done by Andreas Brunklaus and colleague, that are trying to help to unravel and help us to understand the functional effects of any of these variants so that we can be informed when we are trying to use the therapy. So I don't know how much more time I have, but I think that would be kind of my initial rebuttal, because I'm looking at it as an adult epileptologist. I see that the genetic access to genetic testing is changing my practice, and is essentially changing also, it's helping also my patients. Access to care, access to support groups, and actually opening for us new avenues where we are looking at alternative treatments. And then one last point, I would say that if we understand our patients molecularly, maybe we can also develop more randomized controlled trials, such as that pioneered by Ingrid Schaeffer that looked at the KCNT1, and we have now better understanding why some of the therapies may not be working in these patients.
Thank you. Thank you, Nicola.
Thank you, Alicia. Yeah, thank you, Mike. Yeah, I have to say, I mean, I agree, of course, with you, Alicia. No doubts that genetics is changing how we manage patients with difficult to treat epilepsies. There's no doubt. But if you read through the question, has genetic testing improved care? Yes, it is, but it is how much we expected 10 years ago. I mean, what I'm saying is that we have a lot of genes. We know etiology for a number of developmental and epileptic encephalopathies which were undiagnosed since 10 years ago. So we have genes, but we still, after 10 years, we have diagnosis. We don't have a new way of caring those patients. We don't have significant new possibilities for such patients. I'm sure that this is something that will happen in some time. I'm sure that it is something that is my talk is going to be very old in few years. Hopefully, I hope so. But still now we're missing the right treatment. We're missing the right management. And from one side, from the other side, I have to agree with you that of course, we may have genetic counseling with those patients. We may, at least we know that for some patients, we don't have to give some medication because they may worsen the clinical pictures. I mean, we know a lot of things, but the curve that is very nicely represented in the paper, in the 2017 paper, with a number of new genes going up and up very quickly. It's not the same curve in terms of care, in terms of managing. It's not as rapid as it is the curve of the new genes that we have. And regarding all the other issues, of course, I agree with you. I test every patient that are doing a pre-surgical evaluation. They go also for genetic testing, as you mentioned. And every patient that's with a new onset epilepsy in the first 5 years of life, they have a gene testing. Of course, they have, and it changes a lot since some years ago, but still, and this is also very important for young physicians that grow up in when also genetic is established very deeply, and not as hard that we learned before the phenotypes and then we learned about genetics. So a number of young physicians, they want to have the name of the gene, they want to have the name of the etiology, but then they're missing the findings, the clinical findings. They're missing details. They don't look at polygraphy. They don't look at the ECG. I mean, it's not for everyone, but just a message to say, okay, let's go back on the phenotype. Let's keep the genetic because it's very useful, but let's say that the genetic is not all. With the mutation, we're not resolving the clinical picture, and we're not resolving the problem. Thank you.
Thank you. Let us open it to questions from the audience, which I don't see any written, but I will pose one question to both of you, and that is, I guess for Alicia, you can start, and then Nicola, if you can do it as well. And we've only got a couple of minutes for this because then we have to have a vote. Is there a typical sort of profile pattern that you would look for the patients who you think it's worth testing? And obviously children are different than adults. So I would ask you to do it by age. Maybe Alicia, you could address the adults, and Nicola, you could address the children.
Yeah, sure. Thank you, Mark. Okay. A profile of a patient to be tested. As I was mentioning, we're right now testing the majority of patients. However, if I have to say, do you have a profile, and do you bet on a genetic request if it's going to turn positive or not? I bet in a patient in the first year of life with maybe normal MRI, with early onset epilepsy, with bilateral epileptiform abnormalities, with maybe a seizure starting from both hemispheres, and without any other clear-cut etiology. On that one, I would bet and for a genetic positive result.
Thank you. Alicia?
My answer is rather simple. I think it's on the adult side, about estimated 30% of patients would be lesional acquired, so-called acquired epilepsies. And so those will be the ones that I would may exclude those. Everybody else is a candidate for testing, and we are more struggling with being able to have access to that and being able to actually provide the diagnosis. And also majority of the patients will have focal epilepsies, and this is a big problem for us because those, as nicely illustrated by the study by Peruka, is that we resolve only about 12% of those patients genetically, and many of those epilepsies are brain restricted. So, sorry, deviating from a very simple question, majority of the patients, unless they come with head trauma or infectious causes of their epilepsy, they are candidate for testing.
And do you think that patients with dysplasia should routinely be tested?
I think that it's important that we do and that we try. There are different avenues now that we can use for testing them, but we should do and we should try because that's the only way we are going to also learn. There is a small proportion that we will be able to resolve from their blood sample, and then there are other ways we can try to dig deeper to try to understand them. But I guess that's more of a debate for a different time.
Okay, thank you. So now we will have a vote again. And again, the question is, has genetic testing rather improved care for people with epilepsy? If the audience would please vote. We had previously, prior to the speaker speaking, 78% yes and 22% no. Let's see what our answer is at this point. So everyone please vote. And I want to thank both of our speakers for really excellent jobs. I learned a lot. Okay, so we have two winners for our debate. The vote before was 78% yes and 22% no. The vote after is 66% yes and 34% no. So Professor Specchio has clearly convinced more people than Professor Goldman. On the other hand, most people still agree with Dr. Goldman, so she still is correct.
Consolation prize.
on that end. I think this highlights the interesting nature of this question, and it's a good debate that I think is worth an answer. Alicia, it would be a nice topic, and Nicola for maybe taking this and putting something like this into epilepsy, frankly, if you're both interested in doing something to sort of list the pros and cons and maybe highlight some profiles of where genetic testing would be best. I think it would be informative for everyone. And I think the associate editor for genetics of epilepsy probably would be very favorably disposed. who's Dr. Goldman and the editor, and me, but also be favorably disposed. And Nicola will have to get you onto the committee as well in some fashion soon, I think. Okay, well, thank you both very much. We'll move to the last debate.
Thank you very much.
Thank you, Mike. Appreciate it.
Bye.
I
Thank
thank
you,
our
Mike.
speakers. They're really terrific. It's really good.